I think it's very evident from what we've shared today that the assistance that we're providing has been long-standing. It has not gone away. It is not going away. And it is many magnitudes of order greater than just about any other partner, particularly in the health sector. But other areas, as I pointed to a moment ago, in refugees, our commitment is very strong. And it is, if you look at the stability of this assistance over the years throughout changes in bilateral relations, throughout times of challenge, it has continued to be strong. And that is first and foremost because our partnership with the Ugandan people has remained strong, and I'm very confident will continue to do so. So our work is focused on results. It's focused on investing in people, in achieving, in this case, health solutions at the individual level, but also at the systemic level. And we're not driven by polling or anything of that nature. We're driven by a goal to achieve results in partnership with the Ugandan people.
Thank you, Ambassador. I would just ask,
I think it's very evident from what we've shared today that the assistance that we're providing has been long-standing. It has not gone away. It is not going away. And it is many magnitudes of order greater than just about any other partner, particularly in the health sector. But other areas, as I pointed to a moment ago, in refugees, our commitment is very strong. And it is, if you look at the stability of this assistance over the years throughout changes in bilateral relations, throughout times of challenge, it has continued to be strong. And that is first and foremost because our partnership with the Ugandan people has remained strong, and I'm very confident will continue to do so. So our work is focused on results. It's focused on investing in people, in achieving, in this case, health solutions at the individual level, but also at the systemic level. And we're not driven by polling or anything of that nature. We're driven by a goal to achieve results in partnership with the Ugandan people.
Thank you, Ambassador. I would just ask,
donor and contributor and funder of refugee assistance here in Uganda and worldwide, covering approximately 50% of all of the costs that in terms of humanitarian support, as well as in development areas, education, but also in health. And we've supported the construction, actually, of clinics, training of healthcare workers, medicines, stocking these facilities in refugee hosting communities. And it's very important to know that, again, with about 1.6 million refugees here in Uganda at the moment, this assistance is not only benefiting them, but benefiting the Ugandan communities in which they are living and that are around the settlements where they're at. And we estimate nearly 3 million Ugandans benefit from that support as well. So through not only health areas, as we're talking about today, but in other areas as well, we are supporting refugees as well as refugee hosting communities. And that is, again, something that we have worked very closely with Ugandan authorities, worked very closely through UN agencies and local implementing partners to execute over decades of support here in Uganda.
Thank you. We'll turn to questions.
As I mentioned at the beginning, approximately a little over 500 million, close to 550 million of funding annually through our mission here, our U.S. government mission here in Uganda. That doesn't even capture assistance and support that we provide through multilateral organizations like Gavi on vaccine work, for example, through Global Fund for HIV. So it's even greater when you consider the resources that are coming through multilateral organizations. But here, bilaterally through our mission, around over $500 million just in health. In terms of funding, and my colleagues can talk about specific programs, of course, we do want to support sustainability. We do want partner countries to make progress to where assistance is graduated from. But again, I think what has come hopefully clear through our presentations today is the assistance that we have provided over the years has been very sustained. It has been very continuous in terms of levels, and we have continued to achieve results with that support. So while fiscal resources are always tight and there's always many other demands, and we can never project precisely many years in advance what the funding is going to be, we have been able to successfully maintain funding in key areas, including malaria as well as HIV prevention. Thank you, Patrick. Thank you for the question. The commitment of the United States of working with the Ugandan people has gone for decades, and it has continued to be very strong. Our investment is, again, in people. It is in health, as we're talking about today. It's in education. It's in many, many other areas. And our support, of course, is intended to build a future in which donor assistance is no longer needed. We seek, as a partner of the Ugandan people, to help in a way that provides the stepping stones to prosperity, to education, and to the programs that we're talking today, to a healthier lives for individuals and their communities. Obviously, there are other countries, there are other entities that are every sovereign nation can engage with, and countries as they engage. That's certainly part of normal international relations, but for us, as the largest partner of Uganda and have been for a long time, our commitment has remained strong and is going to continue to remain strong, working not only in the health space to achieve the results that we've detailed today, but to continue to build a path towards a future in which donor assistance and international aid is graduated from, and the local capacity here is able to address all the needs that the Ugandan people have. Disease, and it has been one that goes up and goes down. We've ultimately seen very strong results in communities that are high burden for malaria prevention, where we've been supporting activities through the U.S. President's Malaria Initiative. Just last week, I had the privilege of going out to Namatumba and seeing some of the activities that we've supported there, and seeing through working on very community-based approaches, spraying, residual spraying, use of bed nets, training people to cut back vegetation that prevents the proliferation of mosquitoes, for example. Very basic but very important actions that have had key results. And in a community, for example, as I visited, where the incidence and prevalence of malaria was very high, above 55%, they've cut it by over 25% just in the last 2 years. So seeing those results it is possible to achieve important things, but it does take a community-based approach. It does take a consistent approach because it's very easy for mosquitoes to come back and for practices to wane and for incidents of malaria to creep up rapidly and, of course, pose a danger to the entire community.
Aren't always well known. Cervical cancer. Cervical cancer is the leading cause of cancer-related death among women in Uganda. It steals our mothers. It's always women aged 25 to 49. In 2020, almost 7,000 women were reported to have cervical cancer. 4,600, more than 4,600 of those died, more than 50%. Cervical cancer is preventable if you catch it early, but you have to have screening. So in 2020, the Ministry of Health announced that they wanted to scale up cervical cancer screening. So the CDC stepped in, used PEPFAR funding, U.S. government in general, actually, PEPFAR stepped in, but we made sure that cervical cancer screening was everywhere that we were, and all the clinics providing HIV services. In the first 3 years, just the clinics that CDC works with did 540,000 screenings, that's in 3 years, and they discovered 35,000 Ugandan women who had precancerous lesions and were able to refer them to treatment. So that's 35,000 women who are at extremely high risk of progressing to cervical cancer and even death had they not received the screening and been identified. Drug addiction, right? In the U.S., we are the public health agency of the United States. We're fighting a big opioid drug addiction outbreak. It's happening everywhere in the world, though. So we've been trying to bring lessons learned and expertise everywhere we are. Here in Uganda, we have partnered again with Ugandan agencies, Uganda Harm Reduction Network, as well as Reach Out in Mbuya, at Budabika National Referral Mental Health Hospital, and built some infrastructure, capacity building, and started working on the issue of drug addiction. In the first few years of that program, 500 people or more have enrolled, and 171 people so far have graduated and been able to reclaim their lives from the illness of drug addiction. And I'll just say we also take lessons learned back to the U.S. Again, the way we operate is through partnerships with other countries. We're all part of the Global Health Security Network. So during COVID-19, we collaborated with brilliant U.S. experts and doctors to help Uganda establish a triage and ambulance system as part of the emergency medical services systems. In a very short amount of time and with very little money, with our CDC support, Ugandan experts and physicians were able to create a triage system that persists to this day and is all around the country. When you go to
or avoid relationships that could be violence-inducing. For those who have been victims of violence, supporting.
It was a little bit different. It's not an agency of the U.S. government, it's a program. And it's coordinated by the State Department and implemented by DoD, CDC, USAID, Peace Corps. And it serves all districts of Uganda. So most of you know PEPFAR. Over the last 20 years, it was launched in 2003, and Uganda was one of the first countries where it was implemented, one of the first partner countries, which is quite a long-standing partnership at this point. And building on that, we've also worked towards that localization effort, that local entities implement PEPFAR and ensure that our programming reaches those who are most vulnerable. And that's a key principle, is health equity, and why we serve the entire country. 100% of districts receive PEPFAR services, both direct service delivery for HIV prevention, care, and treatment. We've heard a bit about the lesser-known aspects of PEPFAR, one of those being cervical cancer screening. So if you look across the interagency, across the country, over the last 3 years, nearly 650,000 women living with HIV had the opportunity for screening. Some of those, as Dr. Amy Bohr said, were found to be positive and referred for treatment. So this is an important aspect of the program that is not only addressing HIV specifically, but also opportunistic infections. We see that in our TB work as well. So over 123,000 people began TB preventative therapy last year alone, and this is a key success. As we look at how do we even know all of these numbers, another lesser discussed part, but a very important part of the PEPFAR program is strategic information and health information systems. So these health information systems are truly to support our digital health systems of how do we know where we're at in the epidemic. And well over 1,500 sites implement the electronic medical record system to help us track the services that are provided, the care that's received, and also help us identify the gaps. What are people not receiving that they need as well? So as we look at more than 1.3 million clients being served, people living with HIV who are receiving the care that they need, we want to continue to scale up access and improve our data systems as well. So that's related to a core principle that PEPFAR makes data-driven decisions and that we're really based on evidence and evidence-based interventions. And also that we're dedicated.
The work that we do and have done in terms of prevention or victims of violence, primarily sexual violence and gender-based violence, and
lymphoma affecting children in Uganda, and that's still a very active area for us. The mission of the NIH is really to provide solutions to the most critical health problems through research and discovery. And some of the examples, Uganda's really been at the forefront of discovery over the last several decades. And just to give you a couple of examples of some of the U.S. government research that has really both impacted Uganda but countries surrounding. The Makerere University, Johns Hopkins University collaboration, which sits on the Malago Hospital campus, was one of the pioneers in developing prevention of mother-to-child transmission tools. So they really demonstrated the impact of using antiretrovirals to prevent prevention of mother-to-child transmission of HIV. The Rakai Health Sciences program.
I'd like to highlight that our health information, our data, our program results are publicly available, and that's on PEPFAR Panorama Spotlight. So even if you just Googled it now, you would see the data available for Uganda, but also across the globe where PEPFAR works. And we, of course, want to share more. So I'll stop there and look forward to your questions.
Malaria Day, the U.S. government launched its malaria strategy with a focus on climate change, because we do recognize that it's having a huge impact. Weather patterns are changing, and so we want to make sure that we're keeping up with what's happening and making sure that those interventions that are out there continue to have a great impact. But again, very important to note that we must not become complacent, right? It takes all of us. We must keep up our efforts in order for us to be able to prevent malaria.
For years, continues to be, and is increasingly so. And so as we look at service access, we, within PEPFAR, went through a series with our implementing partners, with healthcare workers, ensuring that there are adaptations to the program so that services continue to be accessible to the people who need them most. So as we look at moving services into the community where they're available in safe spaces, health clinics, and that individuals who have the capacity to provide those services are available as well, that they're trained, is important and essential. So that impacts some of the efficiencies that we've found over the years. As we've discussed, PEPFAR has been collaborating with Uganda for over 20 years. And during that time, we have become much more efficient and targeted in our approaches in both preventing HIV and in providing treatment, and very effective treatments. And that's moved into providing the latest in drug regimens as well, that are the easiest on the body, the easiest to take, that are very different from our original medications that were available. So as we look at some of that, where we're at today, it does move us back in service delivery, and we need to continue to address stigma and discrimination throughout. That's also then related to the question around stagnating new infections. So we have
finding ways to support them, either in the first instance in prevention, and one of the key areas preventing gender-based violence and sexual violence is supporting livelihood.
Different review boards, and it should be implemented soon. But I also want you to know that there are 3 different vaccine candidates that were supposed to be trialed, and we are already moving forward with one of the 3. It is a vaccine.
Lymphoma affecting children in Uganda, and that's still a very active area for us. The mission of the NIH is really to provide solutions to the most critical health problems through research and discovery. And some of the examples, Uganda's really been at the forefront of discovery over the last several decades. And just to give you a couple of examples of some of the U.S. government research that has really both impacted Uganda but countries surrounding. The Makerere University, Johns Hopkins University collaboration, which sits on the Malago Hospital campus, was one of the pioneers in developing prevention of mother-to-child transmission tools. So they really demonstrated the impact of using antiretrovirals to prevent prevention of mother-to-child transmission of HIV. The Rakai Health Sciences program.
In Uganda, we know that adolescent girls and young women, the ages of 15 to 24, are at highest risk. And we need to continue to ensure that prevention interventions are available and that we address that cycle of transmission so that everyone who has HIV, knows their status, and doesn't continue to transmit. So as we address that, it is multifaceted. We do need to work together, and that's one of the reasons why we come together during the country operational planning process between communities, civil society, young people to provide input and direction on what's going to reach young people. We don't want to sit in isolation. We need to involve the people that are touched by these services to really direct in what's going to be most effective programming. But as we look forward, we want to continue to do that, to continue to maintain those discussions. As we see the HIV epidemic curve, it has stagnated, and we need to bend that curve. We need to reduce new infections as well as HIV-related deaths.
Across the country, where it's not just health, it's all of the different programs. And to be honest, what you heard today isn't even anywhere close to all of the programs, and so you can imagine it's really difficult.
It becomes great. We can get ahead of the curve, and I think that Uganda has done a tremendous job in doing that, in the sense that
Probably over time. So I'll just end with Immunization Week. You've already heard we are in Immunization Week. You've heard that we are one of the biggest
Defense and military are fighting terrorism and wars and such, but we also fight diseases. And that is really important here because there are research studies. So we were invited in 1998 and we started our operations here in Uganda. And in 2002 we established, in partnership with Makerere University, we established the Makerere University Walter Reed project that many of you have heard of in many capacities in the country. So we have a long-standing collaboration. All our work is done through Ugandan partners, as CDC and USAID have mentioned. We also work exclusively with Ugandan institutions such as Makerere University and the Infectious Diseases Institute. And our role here is mainly falls into three pillars. One is health security. Two is developing new products, for health products, and three is providing health services. So I'll expand a little bit on each. On the health security front, we have active surveillance that we share with the government of Uganda and also the governments of Kenya and Tanzania, because diseases are not limited to one country. They travel quickly and they travel fast. So we, in order to control an outbreak when it is happening, it is important that everybody comes together to control the outbreak. So we have active surveillance looking at respiratory viruses such as COVID, you talk flu, we have adenovirus, Boca virus, respiratory syncytial virus. A lot of the things when you see like having flu-like symptoms, we monitor the spread of these viruses and share with the ministries of health so that we can together with the U.S. government support develop an active outbreak response. The second thing is I want to touch on the health products development, and this is very important in Uganda because Uganda has been at the forefront of developing new vaccines. And while the U.S. government has been supportive since the beginning, it is also Ugandan capacity that led us to support and work in collaboration with our Ugandan partners. For example, the first Ebola vaccine trial in Africa, in all of the African continent, was done in Uganda in 2009, and that was done with U.S. government, with the U.S. Department of Defense, the Walter Reed Army Institute of Research, and the Makerere University Walter Reed Project launched the first ever Ebola vaccine trial in Africa. And you all know now, because of what Uganda has contributed to the global vaccine space, we now have a vaccine for the Zaire strain of Ebola. And that was made possible because of the U.S. government and Ugandan collaboration and partnership. The second thing I'll talk about is a lot of HIV vaccine research, and I know my colleagues too will also touch on it from the NIH side. But we have been in partnership with the Ugandan counterparts supporting new HIV vaccine trials. In fact, just last month we launched a new vaccine trial called Rapid Vax with Makerere University to explore new types of HIV vaccine candidates. Lastly, on the health services delivery side, we also implement PEPFAR along with our sister agencies CDC and USAID, and the Department of Defense has always been supportive of hard-to-reach areas. So we do provide a lot of the health services in the islands in Lake Victoria. For example, if you go to Buvuma, Mukono, the islands that belong to Mukono district, like the Kume and Kimi Islands, all those health services are supported by by the Walter Reed Army Institute of Research under the PEPFAR program. So we do also deliver extensive, like the medicines, the health workers, all services in those islands are supported by the U.S. government. I'll end there and then hand it over to Ellen.
I'd like to highlight that our health information, our data, our program results are publicly available, and that's on PEPFAR Panorama Spotlight. So even if you just Googled it now, you would see the data available for Uganda, but also across the globe where PEPFAR works. And we, of course, want to share more. So I'll stop there and look forward to your questions.
Reduce HIV acquisition risk by 60%. These tools have been scaled up by my colleagues that are working in health programming and PEPFAR, and really have had a huge impact on the number of HIV infections. We also support research in a broad variety of areas: malaria, TB, sexually transmitted infections, non-communicable diseases, and cancer research, in collaboration with Ugandan institutions such as JCRC, UVRI, Macquarie, Mbarara University, and many others. The other focus of our institution really is to support training of the next generation of Ugandan scientists, and that's been a core value in our mission here since the inception. Through the Fogarty International Center, which is based at the NIH, we provide training grants to Ugandan institutions such as our Kai Health Sciences Program and the Infectious Diseases Institute to train Ugandan scientists at the master's and PhD level, and really to lead the next generation of scientists when new emerging health threats occur. We also provide infrastructure support to training institutions. So we recently launched the African Center of Excellence in Bioinformatics, which is based at the Infectious Diseases Institute, but supports training programs in bioinformatics at Macquarie University at the master's and PhD level. And this is really allowing Ugandan scientists to do very complicated data analysis that used to be done outside Uganda, but now can be done in-house. That center also has a state-of-the-art virtual reality classroom that's really been instrumental in training health workers and medical students in several areas of critical learning needs. Just to end with an impact, just to show you maybe an example of how we've had what I think is a big impact. Around 2011, 2012, we started working in the fish landing sites on the shores of Lake Victoria. Many of you know that those areas are some of the hardest hit areas of HIV, with extremely high rates of HIV affecting those communities. We did a rapid scale-up of evidence-based combination HIV prevention over a 5-year period, and we dropped the number of new infections by 50% in those communities in that short period of time. So I think really showing the impact across agencies of how we can have a major impact on communities. So with that, I'll end, and thank you very much.
Thank you, Dr.
We stopped seeing some of these measles outbreaks and deaths among children as we're seeing right now, in addition to working out how the country can more rapidly get vaccines to all age groups. Aren't always well known, cervical cancer. Cervical cancer is the leading cause of cancer-related death among women in Uganda. It steals our mothers. It's always women aged 25 to 49. In 2020, almost 7,000 women were reported to have cervical cancer. 4,600, more than 4,600 of those died, more than 50%. Cervical cancer is preventable if you catch it early, but you have to have screening. So in 2020, the Ministry of Health announced that they wanted to scale up cervical cancer screening. So the CDC stepped in, used PEPFAR funding, U.S. government in general, actually, PEPFAR stepped in, but we made sure that cervical cancer screening was everywhere that we were, and all the clinics providing HIV services. In the first 3 years, just the clinics that CDC works with did 540,000 screenings, that's in 3 years, and they discovered 35,000 Ugandan women who had precancerous lesions, and were able to refer them to treatment. So that's 35,000 women who are at extremely high risk of progressing to cervical cancer and even death had they not received the screening and been identified. Drug addiction, right? In the U.S., we are the public health agency of the United States. We're fighting a big opioid drug addiction outbreak. It's happening everywhere in the world, though. So we've been trying to bring lessons learned and expertise everywhere we are. Here in Uganda, we have partnered again with Ugandan agencies, Uganda Harm Reduction Network, as well as Reach Out in Mbuya, at Budabika National Referral Mental Health Hospital, and built some infrastructure, capacity building, and started working on the issue of drug addiction. In the first few years of that program, 500 people or more have enrolled, and 171 people so far have graduated and been able to reclaim their lives from the illness of drug addiction. And I'll just say we also take lessons learned back to the U.S. Again, the way we operate is through partnerships with other countries. We're all part of the Global Health Security Network. So during COVID-19, we collaborated with brilliant U.S. experts and doctors to help Uganda establish a triage and ambulance system as part of the emergency medical services systems. In a very short amount of time and with very little money, with our CDC support, Ugandan experts and physicians were able to create a triage system that persists to this day and is all around the country. When you go to
Uganda, quoting the East, that's China and Russia, in terms of support. Will this jeopardize the relationship?
Malaria Day, the U.S. government launched its malaria strategy with a focus on climate change, because we do recognize that it's having a huge impact. Weather patterns are changing, and so we want to make sure that we're keeping up with what's happening and making sure that those interventions that are out there continue to have a great impact. But again, very important to note that we must not become complacent, right? It takes all of us. We must keep up our efforts in order for us to be able to prevent malaria.
My name is Norbert. I work with NTV Uganda. In the recent past, government officials have indicated that partners have reduced funding. That also includes helping in bringing
its assistance when it comes to malaria. And I would like to say that since 2006, the U.S. government has invested over $549 million here in Uganda. And last year alone, that amount came to, we invested $34 million. So our investments outside of the multilaterals, as the ambassador mentioned, has been steady, and in fact has increased over the years. And that is why we're able to achieve the results that we have today. 3.4 million people protected from malaria, our ability to continue to provide mosquito nets, our ability to continue doing the work in indoor residual spraying, and so on and so forth. So our assistance remains steady on the malaria front, and in fact, Uganda has been one of the few countries where we continue to see, we've seen an increase.
Young people who are either HIV positive or susceptible to HIV that are also have been either victims of sexual or gender-based violence, or very vulnerable and at high risk to doing so. So one of the key ways that we try to do that is, of course, help them be able to have access to the resources that can prevent them from contracting HIV virus, but also to having access to job skills and training that can build their self-confidence, build their self-esteem, and give them the skills to generate their own resources to avoid maybe behaviors or activities that might bring them into sexual work or other high-risk activities that might put them at extra levels of vulnerability for sexual-based violence.
Walter Reed and the Makerere University both are launching the vaccine trial for the Sanofi vaccine candidate. So that should be happening anytime soon in the next month.
Each of those questions, I'll take the first one, just to mention that yes, we have very carefully scrutinized our programming and activities in the wake of the Anti-Homosexuality Act. above all, our programs must, under U.S. law, be implemented in a way that is non-discriminatory. In other words, any activities that we support financially must be available to all individuals, whether it's a health program, education activities, anything we do. And that is a requirement. So we have sought very clearly to determine and ensure that assistance that we provide at health clinics and education programs and access to services, antiretroviral medicines, in general, everything, that everyone that needs that support can receive it. And we have had to be very clear about that. We have worked very carefully with implementing partners to make sure that individuals, particularly in need of antiretroviral medicines, can have access to them. These are life-saving medicines. These are state-of-the-art responses to, and that over, again, 1.3 million Ugandans are living with, and over 95% of Ugandans with HIV depend upon. And so we have a strong commitment to ensuring that they are able to access them. Funding overall, while we did do a serious and careful examination of our programming following the passage and implementation of the law, we did proceed with our country operating plan, and we have continued to fund all of our activities. We did redirect some funding away from some institutions and organizations, but we have continued to maintain all of the services and activities funded, and our funding for the coming year, we hope will continue to be able to do so. I'm going to pass the vaccine. I don't know, Mary, do you want to add anything to that, please?
How do you want to receive information? We know that it's not everyone, and I think all of you can agree with me that sometimes we're embarrassed to be found anywhere near a health facility for whatever reason. And so we want to make sure that we are able to really parcel out exactly how, where people want to receive information, how they want to receive the services, so that we can create those bespoke types of services. And that's why it's important that we partner with the private sector here in Uganda. It's important that we partner with all of you to be able to provide the information that is needed so that people can seek services early.
Health, I'll let colleagues from USAID discuss. Just want to note that it's an incredibly important aspect of PEPFAR programming as well, as we look at the mental health of the people that we serve, of people coming in for an HIV test, unsure of what that test is going to say, of those who may be at risk for HIV for a variety of reasons, those who have experienced sexual violence, which continues to be a key driver of HIV. We do need to address mental health, and I think that can be done in a variety of ways. Again, education, a certain level of skill, of a sense of belonging in our communities, and to ensure that we have open and honest discussions about where we're at as a community and how we move forward. And I'll hand it over to Danielle.
You asked the question, why mental health? I think mental health is critically important to our ability to achieve development impact. We know that sometimes the signs of mental health are not visible. Depression is not visible. Stigma is not visible, but these are things that make it incredibly difficult for people in many communities around Uganda to be able to actively participate in the economy, to be able to seek livelihoods, opportunities, and to be able to do anything, quite frankly. And so what we want to do here in this technical summit that is ongoing is to bring different stakeholders from government, from development partners, from local actors, to talk about in an open space, because we know that we often don't want to talk about it. We want to normalize mental health, because mental health is an everyday issue. We want to make sure that we can create policies, we can have action plans moving forward on how, whether you work in the private sector, you're able, your staff are able to access mental health services. If you're in government, similarly. But in our development programs across different sectors, how do we make sure that we can integrate that? One of the things we've been able to do, and As the U.S. government agency that principally administers development activities, we're lucky to be able to leverage the different platforms that we have across many sectors. And one of those is looking at how we can leverage, for example, let's say the agriculture sector. When we're talking to farmers, is there an opportunity for us to talk about mental health? When we're talking to in the education space, how do we make sure that we can address this question, again, normalizing this question, so that when people see the signs of mental health, they know what to do, they know where to go, so that we can get better as a society. I think we know that since COVID-19 happened, that we can no longer be ignorant of the impact that mental health can have on all of us. It can have on our economies, it can have on development. So that is what we're trying to achieve in the next 2 days of this mental health summit. And I think Strong Minds has been a part of the U.S. government through USAID, has been able to pilot a number of practices that can be done at low cost in different communities. And so we're hoping that by the end we can get these practices out to scale so that everyone can benefit.
And I noticed something that your implementing partner is struggling. While people, scramble for mosquito nets, it's not the same when it comes to indoor residual.
It's community concerns. So that is something that is ongoing. And we take note, and we'll love to hear more after this to understand exactly where you saw.
Expensive has become more challenging, and so while funding has remained stable, some of the work, particularly again for folks to access services without stigma, without discrimination, we've had to innovate and work with partners to innovate how people, for example, get their antiretroviral medicines. And so that has a cost and it has an impact, even if thus far we've been able to continue to maintain access. It has definitely been more difficult. I don't know if others want to add more to that. Yeah.
So any legal barrier or stigma that prevents access to antiretroviral treatments ultimately impedes our ability to control the HIV epidemic. So we really need to create an environment that is open and easily accessible by all. Because if we could get the entire HIV infected population on antiretrovirals and virally suppressed, then we would be able to control the HIV epidemic and really achieve our goals, which is what we're trying to do. So thank you.
Information to help us get that out there so that we can keep Ugandans as healthy as possible, because I think that